How are you?
I'm well, thank you.
Yeah. How's life?
Good.
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 Thank you for making the trip to New York. We're delighted to have you here. Tell us why diabetes and why, you came from the private sector.
Correct.
You have a background in finance. She's a finance wizard. And when you had the chance to do something different in life, it's kind of like Deepak asking us, what kind of world do we want to create and what are we going to do about it? This is how you answered that question. Tell us about that.
Thank you for inviting me, and thanks to all the people that are here. For me, it came as a dream come true, the opportunity to start a foundation focusing not only on diabetes, but as the NCAP program or NCAP project, because of the huge gap that there is in the market. I always refer to people as market. I've worked a long time in marketing. However, I come from a background where my mother had diabetes for over 20 years and managed it well. And then I had my aunt from my paternal side, whom since I was born have known to be taking tablets and also injections. She was also having type 2 diabetes. Maybe something to highlight before we engage further is that there is nothing called a diabetic. You do not define a person by her illness. A person is a person first and is living with a disease or a condition. So if you were referring to people as diabetics, from today onwards, cancel that word in your vocab. So I'm predominantly or predisposed to diabetes. If we look at the genetical lineage and that if someone in your family had diabetes, so I have bigger chances, more than 50% chances of developing diabetes. So that's one thing that interested me in like investigating further about diabetes. And then also when I had that interest and I had an opportunity to do something, then I started researching about the disease. And it was even more shocking to know that more than 366 million people in the world live with diabetes. That's according to the International Diabetes Federation. And then that an estimated 6.5 million are in South Africa. And that brings the matter closer to home. Right. So we cannot afford to play ignorance anymore. Diabetes does kill 4.6 million a year all over the world. In every 8 seconds, someone somewhere in the world dies because of diabetes. There are more than 1 million amputations. And if you go to the amount of money spent on diabetes, which is about 495 billion US dollars a year. And that money could have been used in infrastructure, in skills development, in poverty alleviation. Right. And if we sit and keep mum about it, that amount is going to double in the next 10 years.
No, it's a huge opportunity lost, and ignoring the rise of non-communicable diseases generally, but diabetes in particular, I think in these emerging and frontier markets will come at a heavy cost, not just human, but also economic. But let me ask you, South Africa in particular, is Ige around? I was going to say it's the leading country in Africa, but if I say that and Ige's around, I'll get in trouble because it's all it is. Nigeria, of course.
It depends from which angle you're looking at it.
It depends. In many respects, South Africa is the leading country in the African continent. Undergoing rapid change, development, urbanization, how do these dynamics impact on non-communicable diseases and on diabetes in particular? What are you seeing there?
There's a huge shift because with development and many companies coming to invest in South Africa, in South Africa, you get a lot of movement from people who were living in rural areas coming into the urban areas because of job opportunities. And therefore, their lifestyle changes. So diabetes in the past was viewed as the disease of the white or of the rich people. However, the trend has changed because they come now, people flock into the cities and they live in the smallest, square meters per person. They have to wake up early and go to work, come back very late, there's no time to cook proper meal. And also the access to food that they used to plant and eat purely organic food. Now people buy from spaza shops, that's what we call it at home. Then they buy junk food. And then now we're seeing the escalation of diabetes. Even in younger people, diabetes type 2 used to be an elderly person's disease, and then type 1 was called juvenile diabetes. But all of that is mixed up now.
Okay. Tell us a little bit about some of the programs at the foundation. And I really want people to hear Bongi's vision for what the foundation is doing already and will do in the future. And I think, from the perspective of GBCHealth, we're very eager and to be talking in conversation with you about partnerships and things that we can do together. And I think that there are a lot of people out here who would like to know also just exactly, where are the entry points with the foundation and how can we collaborate?
Yes, there is a big room for collaboration, and actually that's how we go to market. We go with strategic partners. Number one, we partner a great deal with government in all its tiers, from national to provincial to district departments. Reason, the Department of Health are the custodians of the health of South Africans or anyone who is in South Africa at any given stage. So whatever messages that we take out to the market should be aligned to what the government is ready to deliver. It would be no use looking at what America is doing and then telling people that now we can log on at home and tell the doctor that is my readings are like this, so should I modify my medication? Or because most of the people that I'm targeting do not even know what the computer looks like.
What about cultural influences in South Africa in particular? You and I had a very interesting conversation on Saturday in which you talked to me about African men, black men in Africa, and their expectations about their own bodies and about the bodies of women that they're with. And you said, we've got to own this. We can't just sweep this under the rug anymore.
We have, when you say the South African culture, South Africa is a country with different segments, if I can call it that way. You have the elite people who live in urban areas and live a lifestyle maybe more or less like here. There's people who stay in Sandton, Bryanston. They are, some of them, black. And then you have people that stay in the townships, and then you have people, a huge number, in the rural areas. So those people, you address them differently. Same message, but different method of addressing their issues. What has come up in most of our outreach campaigns is that we see that men are not very much keen to go forward and test or screen, because we preach that people should screen so that you can know early whether you are at risk of developing diabetes or not, and then bring interventions early enough so that you save your life or complications. Men tend to be slower in coming in numbers. And then we had last year in our World Diabetes Day, which we held in Sasolburg, that is one of the provinces in Bloemfontein. We had one man who participated in the event. We started with a walk of about 5.5 kilometers. He's 70 years old, he's lived with diabetes for 20 years. So he was one of the people leading the walk. And he was saying, I'm happy for the opportunity to share with other men that the stigma that says when you have diabetes, you are not man enough, because there is a complication that is linked to your erectile dysfunction. That is if you do not comply to your medication and if you do not do as the doctor tells you. But if you do that, if you exercise, if you eat nutritiously, if you do take your medication on time and as you are told, because there's a reason for the doctor to tell you to snack at 10 p.m., he knows that the injection that you are taking is going to kick off maybe 6 hours when you're sleeping, and when at the time that your sugar levels go down, then that snack is there to balance. So if you don't take that snack, then you are likely to wake up in a very awkward situation.
Yeah. In many foundations of working in the global health space, there's a track of work on prevention, a track of work on treatment, a track of work on advocacy and public education. Tell us about how those different tracks fit in the Bongi Foundation.
We are, as South Africa or as Africa or as the world, because diabetes is at a crisis level. Actually, the president of International Diabetes Federation described it as the societal, catastrophe. It's no longer just a health problem, but it affects everyone, the economies and everything. So we do not have the pleasure of having to deal with one aspect of it. So we do awareness, we do education, education, teaching people how to manage and care for themselves, taking control of their lives. And also, so we have programs that talk to the different people. That one, our priority are people that are living with diabetes, to say diabetes is not a death threat. Right. My mother lived with it over 20 years, right, and she was fine.
I want to come back on something you said earlier and maybe try to put a very fine point on it. Would you agree with what I said in the introduction, that there is a stigma attached to diabetes?
What happens is when a person is diagnosed with diabetes, people tend to pick on that person. The minute you your food, and then people, you don't eat that because you don't, So then people tend not to share that they have the condition, because then people will start, even the family members. That is why education is important, not only to the person with diabetes, but family members, because they need to be there to support the person.
And do we see this, and by this, let me say, I think both the incidence of diabetes and the treatment of people with diabetes, do we see the same thing in the larger cities and in rural areas where so many people live in South Africa still?
Well, in larger cities, though people are there in big numbers, at least there is infrastructure. Yeah. Healthcare systems are different from rural areas. If I can quote one area where we come from or originate from, in Melmoth, in our area, the clinic is here, and in the 20 kilometers radius, there is no other clinic. So if you complicate, you have to be taken to a hospital. You will sleep over at the clinic for the ambulance to take you the next day to the hospital. And going to the clinic, there is no taxi or bus. Right. So there is a difference in that people living in urban areas have access to medication easier than the people in the rural areas. Hence, we want to maybe enhance on what the HIV and AIDS programs have done, or learn from that, and use the very same home-based caregivers, but equip them with knowledge and education to be able to educate people about diabetes, so that when they visit a household to see someone who is HIV positive, that person with HIV could also be diabetic. Right. Or there could be a member of the same family who has diabetes. So if we can use the same, so that we don't reinvent the wheel, but empower those home-based caregivers and give them the knowledge, the correct knowledge about diabetes, then they can educate people.
I agree. I think that there are some tremendous cost savings through the integration, and we talked about this very early yesterday, about how we need to move away from the silos. I know that we've been talking about this now on and off for the last, 5 or 6 years, but I think the time has really come when technology and the existence of complementary platforms for different diseases actually allows us to link and tie those platforms together today in a way that we probably couldn't have 4 or 5 years ago. But now, I think so much has been invested in South Africa on HIV, rightly so. So much more needs to be done, but those platforms they're robust enough, they're smart enough that they can easily handle something like diabetes.
Yes. Okay, also the downside is we have few NGOs that are talking about diabetes. We do not have enough advocates for diabetes or non-communicable diseases in general, because we view it within a cluster of non-communicable. That's a strategy that our government uses, and we don't single it out. In whatever campaign, though, that we do, we invite an NGO that does HIV and AIDS, counseling and testing. So we will never go to a community with just non-communicable diseases screening and testing. We will always invite, if we cannot find an NGO in that area or someone ready to come with us, then we invite the government. So we always work hand in hand with the government. They have the resources, they have the nurses, they have the equipment. But then also, we do get help from the private sector.
You have a special contact in the government, I think, don't you?
Believe me, we have a very enthusiastic Minister of Health.
Yes,
who is so passionate about making the health of every South African better.
Yeah.
So if you come up with something that will assist in any way, he will support.
Yeah.
But then I think platforms like GBC are opening eyes even to those companies that were not previously involved in making the lives of people better, and giving them a platform to say, through collaboration, there are people, we are NGOs, we have the know-how, we belong to those communities that we serve, we know and understand the culture and the language that is suitable for each and every different community. Then we need the private sector to give us funding to roll out our strategies.
Right.
But we need the government for policy and guidance.
Absolutely. No, I mean, I think everything that we do at GBC Health, whether it's in China, Russia, Africa, it doesn't matter. The United States, when we did an HIV program in the United States with a number of the companies in this room, we do that in concert, hand in hand, with governments at whatever level is appropriate. So whether it's the White House or the mayor's office, we ensure that collaboration and that integration. I very rudely cut you off. I apologize, but you were just getting ready to talk about a very important topic, and that is your experience with the private sector. Have you started working yet with many companies, and what has your experience been?
My experience has been good and bad, in the sense that through my thinking, I thought maybe working with pharmaceuticals would be the best way, because they understand the impact, they understand the crisis that we're in the space of diabetes. There is a good and bad, that they have the equipment, however, they're not willing to fund. So in my thinking, because I come from a marketing background, it's easier to give me your product and get your advertisement for free through the foundation, but you don't want to make the foundation have enough engine to execute its own strategy, because being an NGO does not mean that I'm illiterate.
Right.
It's the passion I have to make a difference in this space.
Could you repeat that?
I come...
As the president of an NGO, that just like...
does not mean I'm illiterate and that I'm ashamed. No, I'm doing this. I'm not getting paid. I have a strategy done by a professional strategist. I have a media liaison person who is an expert in that, working for a global consulting firm. I have all professionals as trustees of the foundation. I have Dr. Tiliza here with me, who is a medical professional. So what I need from the company that I approach is not to tell me how to feed my own baby, which I started. Because you go to the companies and they tell you, we have this program, how can you fit yourself? No, that's not what I want. I have my strategy, I believe in it. And I know all the statistics. I know the market, I understand it. I'm from those communities.
Right.
All that I need is someone to believe in me, that I can execute what I believe in.
Yeah, well, I think, what's interesting that I experience almost every day, there are some companies who are very new to this work and who have very little experience in partnering with NGOs, and then you have the GBC membership who do a great job and who have an awful lot of experience and who have teams of experts themselves and specialists who share the passion and who have the knowledge about how to do these partnerships. and that's really terrific. I think that over the course of the coming weeks and months and years, as you continue to develop this work and lead the work in South Africa around diabetes and nutrition, what I can say from our perspective is that we're with you. And I know that we've already started a dialogue about partnership in South Africa and with the government, both at the federal level and at the municipal level, with the Mayor Parks Tau from Johannesburg, who spoke yesterday. And we're really committed. We believe that working in South Africa on diabetes and nutrition, which is the crucible, it's really the context of this challenge. Working on that together with you, I think, will be very, very productive. And I know that we will have many, many of our member companies interested, and all we have to do is get started, and I look forward to visiting you in Johannesburg next time. I can't promise to wear such a beautiful outfit.
I'll give you one.
Okay.
I'll organize one for you.
Yeah, John will do drag in Joburg. No. So, wow. Thank you so much. I want to commend you. There are first ladies in the world, and then there are first ladies, and you do a tremendous job. You could have chosen any number of things to spend your time. You're a full-time mom on top of everything else, and with a stellar, exciting, dynamic career in business, a busy husband, and kind of a formal life at the political level. The fact that you have identified this issue, have put it on the radar screen for your country, a country which serves as a barometer and as a real example for the rest of the region, it means a huge amount, and it'll be our honor to partner with you going forward, okay?
Thank you. I would like to share my vision again with you, that our vision as the Bongi Ngema-Zuma Foundation is that we would like to see a South Africa where diabetes ceases to be a killer due to lack of awareness. So our key focus is on awareness and education. But we do have other pillars. We look at vulnerable communities, for instance, which is women and children. Education is the cornerstone for growth for any developing country. So it's also our point of where we focus through strategic partnerships where we can. But wherever we go, whether it's development of women or rural women, like the women that made these bids, they are a consortium of 10 or a membership of 10 women. Amongst the 10 of them, they feed 170 children who are orphans from their own kids who passed away because of HIV and AIDS. Right. So whether we empower these women to make their life better, we will still do something, but we will have a diabetes message coupled with what we're doing.
Fantastic. Thank you so much.